Ma'am, I have made you the co-host. You can share the screen and start the class now.
Okay. Is the screen visible?
Yes, ma'am.
Okay, I'll start. Hello all. Today's topic is going to be skin, and we're going to revise it very rapidly. Few frequently asked questions and high yield topics for all subjects. Okay. So this is going to be a quick 90-day revision program for your final exams. And we are going to discuss all the high yield topics. Today we are going to discuss long essay questions, short essay and short answer question along with a few MCQs. So in Auricle, we have recorded classes, live classes, practical sessions, exam module, and also hard copy books. Recorded classes are very well structured for flexible learning and convenient revision. Live classes, we have in-depth coverage of all topics, including all the concepts which you need to know. Exam module has a quick way of covering syllabus in 20 hours, which you can quickly revise, quickly look into the lectures and then write your exam. We also cover exam questions and frequently asked questions in the express exam module. There is a one-to-one doubt clearing session. Hard copies are very well for flexible learning. Question banks we have with NEET PG level and also Proff exam level difficulties. Practical sessions are very unique with hands-on experience and expert guidance. You can check out the subscription plans in the website. So today's first case is a 49-year-old male with ulcerated foot and pigmented nodule. So note here, these are the two important words, ulcerated and pigmented. Okay. What do you think when, in case, I'm just telling you a scenario, they have given you a scenario of a ulcerated wound in the foot, okay, without giving the word pigmented, then your first thought should go into squamous cell carcinoma, okay. But since they have given ulcerated and pigmented, pigmented is a very key word, ulceration and pigmentation, both happens in melanoma. Okay, this is not a benign condition because benign nevus or any other benign nevi which is pigmented can have a pigmented nodule, but ulceration cannot be usually seen in a benign condition. So this is a melanoma. The likely diagnosis here is malignant melanoma. So They have asked you the mechanism of metastasis. Usually, any tumor, the mechanism is the tumor cells detach, they separate from one another from the surrounding tissue, that is, which is known as the extracellular matrix. They detach from the surrounding tissue. They enter either the lymphatic tissue or they enter the blood vessels. This is the common mechanism of any tumor cell metastasis. But melanoma, apart from these two, lymphatic and blood vessel metastasis, melanoma can locally spread also. Skin tumors can locally also spread. So we have three mechanisms over here. Locally spreading to the adjacent tissues, lymphatics, separating cells detaching from one another as well as from the surrounding tissues, and spread through lymphatics as well as blood vessels. As we already discussed, the routes of spread are lymphatic spread. Lymphatic spread, what will happen? Regional lymph nodes. It's going to affect the regional lymph nodes. Whenever hematogenous spread happens, it can go to distant organs like lung, liver, and brain. So these were the questions which are asked. You can even elaborate on the mechanism of metastasis based on what you learn in neoplasia chapter. Okay, so that is one way to extrapolate the answer. So you can add a few points about melanoma also. The second question we are going to discuss here is precancerous lesions of squamous cell carcinoma. We know the three most important tumors of the skin are melanoma, basal cell carcinoma, and squamous cell carcinoma. So these are the three important tumors of the skin which you have to remember. And they will be asking you questions in melanoma, basal cell carcinoma, as well as squamous cell carcinoma. So, in actin, what are the precancerous lesions? What is precancerous, first of all? You have to know certain tumors have a precancerous condition, which means a condition from which the cancer develops. So, that is precancerous. The name itself here is self-explanatory. So, we have a condition which can transform into cancer in the future. So, this is known as a precancerous condition. Squamous cell carcinoma has two precancerous conditions. The first one is actinic keratosis, and the second one is Bowen's disease. The important difference between these two is actinic keratosis usually occurs in the sun-exposed skin, whereas Bowen's disease need not occur in the sun-exposed skin. Okay, so these are the main differences. Now, how do these lesions look like? Actinic keratosis, they have a very hyperkeratotic scaly flakes over the skin, usually in the sun-exposed areas. Also, you will find this is the squamous epithelium. We know the squamous epithelium of the skin. We know from your first year histology, we know that the skin epithelium of skin is keratinized, stratified squamous epithelium. So there is keratin and then stratification, which means layers. Okay, so keratinized, stratified squamous epithelium is the epithelium of your skin. So there are hyperkeratotic plaques, that is, there is excess production of, there is excess layers of skin. So you have, I can also review a little bit your histology. So the superficial layer is known as the stratum corneum, right? Superficial layer is the stratum corneum. And then there is the stratum lucidum, which can be seen in certain parts of the body, not in all parts of the body. And then we have the granular layer, and then we have the spinosum. And then after the spinosum, there is the basal layer of cells. So this is the epidermis. And then after this, we're going to have the dermis. So basal layer is the last layer of the skin. Okay. So we can see stratum corneum is made up of nothing but dead cells. So this is easy to remember. Basal layer is the layer where stem cells are and skin cells are produced. So it goes all the way up. And stratum corneum is the layer where dead cells are. So you will find dead skin in the stratum corneum layer. Okay. Basal layer, production, maturation, and then dead skin in the stratum corneum layer. Hyperkeratosis is nothing but increase in the stratum corneum layer. So there are lots of dead skins. What does that mean? The turnover is very high. That is what it means. So increased turnover. That is why the stratum corneum layer is getting layered up. So that happens in actinic keratosis. Why? Because there is some damage because of sun exposed area. So there is sun induced or UV induced damage happening, which can lead to these findings. And you can also find solar elastosis, elastic areas in the dermis. Okay, so actinic keratosis done. It is a precancerous lesion. This can go ahead and develop squamous cell carcinoma because there is so much sun damage happening here. It can actually accumulate some kind of mutations and go ahead and cause squamous cell carcinoma. Next one is Bowen's disease. One important thing you have to see, and one more important difference between actinic keratosis and Bowen's disease is actinic keratosis does not have full thickness dysplasia. Whereas Bowen's disease will have full thickness dysplasia. What is full thickness dysplasia? First of all, what is dysplasia? So, from your neoplasia, we know that we have seen the arrangement. So, there is stratum corneum over here, and then there are other layers. Okay, so they're arranged in a very well organized fashion, right? The basal cell is over here, and these cells are arranged in an extremely well organized fashion. Okay, nothing wrong is there. But dysplasia means there is disorganization. There is a polarity which is maintained here. Small cells, polarity means small cells are towards the bottom, basal layer of cells which are small, and the cells which are going ahead up are larger in size. So this is what polarity is. But in dysplasia, there is no maintenance of this polarity. Also, there can be increased size of nucleus. There can be irregular nucleus. There can be mitosis and all these things. But what happens? There is a basement membrane over here below the basal layer. The basement membrane is intact. Okay. So this is what full thickness dysplasia means. From the top to the bottom of epidermis, there is irregularity in cell maintenance and nuclear distortion can happen, but the basement membrane is intact. So this full thickness epidermal dysplasia without invasion, that is what we say without invasion. If there is invasion, then it becomes squamous cell carcinoma. Unless it is there within the basement membrane, it is full thickness dysplasia. So these are the two precancerous lesions, and these are the major differences which you have to remember. Actinic keratosis and Bowen's disease are the two major precancerous lesions of squamous cell carcinoma. Actinic keratosis is seen in sun-exposed skin, Bowen's disease in non-sun-exposed skin, and full thickness dysplasia is a feature of Bowen's disease, but not a feature of actinic keratosis. Okay, so these are the two precancerous lesions. This is the second question. Now we are going to discuss the next question. Factors causing skin cancer and basal cell carcinoma. So these are two questions combined together in my opinion. What are the risk factors of skin cancer? Risk factors of skin cancer as UV radiation, genetic predisposition, fair skin as they say, and immunosuppression. Okay, so let's decode each and every thing. So what happens when there is UV radiation? When there is UV radiation, there is something very unique happens. Usually, as we know, when there is DNA damage, this DNA damage is going to get either repaired or the cell is going to undergo apoptosis. Okay, so molecules such as P53 are responsible for this. Okay, from your general pathology, you might remember that molecules such as P53 are responsible for this process. Whenever there is DNA damage, the cell is going to undergo repair or the cell is going to undergo apoptosis. Because why? Because the cell has to replicate, right? So if the cell has undergone repair, then it will go ahead for replication and it can proliferate into another cell. But if the DNA damage is not repaired, then it is going to undergo apoptosis. So in this case, what is going to happen? UV radiation is going to produce a unique type of DNA damage. It's going to produce pyrimidine dimers. This pyrimidine dimers, our repair system is unable to repair these pyrimidine dimers. It is difficult to repair these pyrimidine dimers. So what happens? Usually, it goes ahead and undergoes apoptosis. When this mechanism is good, then it goes ahead and undergoes apoptosis. Imagine if this apoptosis is faulty. When apoptosis is faulty, what is going to happen is these pyrimidine dimers are going to accumulate. Okay, pyrimidine dimers are going to keep on accumulating, and until they result in a mutation, which finally increases carcinogenesis and result in skin cancer. Okay, so this is what happens. So UV radiation, the main reason is accumulation of pyrimidine dimers. It is difficult to repair these pyrimidine dimers by our mechanism. So whenever it keeps on accumulating, it is predisposed to genetic mutation, which leads to carcinogenesis. So this is what happens. Genetic predisposition is, see, here we have UV radiation causes a pyrimidine dimer, but there are a few genetic conditions which damage our DNA. For example, there are two conditions: ataxia telangiectasia and there is another condition which is known as xeroderma pigmentosum. There is ataxia telangiectasia and there is xeroderma pigmentosum. Okay. So we have to know what is the mechanism by which these conditions cause DNA damage. Xeroderma pigmentosum. So in these two conditions, what happens? There is a genetic mutation which causes DNA damage. Okay, so this DNA damage cannot be repaired by our normal repair system. And the reason is the DNA damage is so intense that it is difficult to repair this DNA damage by using our normal DNA repair system. So whenever this DNA damage keeps on accumulating and worse, if the cells which is damaged by DNA, they go ahead and replicate, then these mutations start accumulating, resulting in carcinogenesis. Okay. Fair skin, as they say, fair skin individuals have less melanin pigment. Okay. Whenever individuals have less melanin pigment, then they are more prone to developing skin carcinoma. So this is very easy. Immunosuppression. Immunosuppression is also a risk factor for developing skin carcinoma. Okay. So these are the risk factors of skin cancer. All right. So these are very easy to remember, and remember these two conditions as well. Now we are going to discuss malignant melanoma. This is the next question. Okay. So what is the etiopathogenesis of this? Can be asked as a case-based question also for you. Okay. Any question here can be asked as a case-based question. So always remember a few points. Always remember the cases. Always remember the clinical scenario with which the question is asked. So we have the etiopathogenesis is UV exposure. We have genetic mutations such as BRAF mutation and NRAS mutation. Now I'm going to just show you the pathway by which melanoma appears. So there's a growth factor over here. Okay, and then this receptor, this membrane receptor is the tyrosine kinase receptor, which has RAS in the cytoplasm as a downregulatory molecule. Okay, and then RAS actually has downregulatory molecules such as PI3K and BRAF. And then we have AKT over here. Okay, and then AKT goes ahead and activates mTOR. mTOR is a nuclear transcriptional factor. So all nuclear transcriptional factors are going to go to the nucleus. These are all in the cytoplasm happening. mTOR goes to the nucleus, and what it does is stimulates the DNA to become RNA. And finally, RNA will induce protein synthesis, and then the cell will proliferate, or cell will increase its survival time. And then here we can see BRAF. BRAF activates MEK here, and then ERK over here, and then we have cyclin D and CDK. Cyclin D and CDK, as we know, are molecules which help in progression of the cell cycle. So the cell cycle is progressed and cell proliferation happens. Okay, but now here very important 2 or 3 things are there which you have to remember. First one is MDM2. What is this MDM2? MDM2 is a molecule which degrades P53. Okay, MDM2 molecule can destroy P53. So whenever MDM2 is high, P53 is low. Whenever P53 is low, cell survival is going to be high, because you know P53 is important in apoptosis. Okay, so whenever MDM2 is low, P53 is going to be high. Whenever P53 is going to be high, then there is going to be decreased proliferation or decreased survival of cells, because P53 is going to check these in keep a check of all these things. All right. So MDM2 you have to remember. This P14 molecule blocks MDM2 so that it doesn't come and degrade P53, and so it keeps a check on cell survival. And then also P10 is also a tumor suppressor gene. We know whatever which stops the cell from proliferating is a tumor suppressor gene. So we have P10 here, which is a tumor suppressor gene. Okay, and then we have another gene here, P14ARF, which is also a tumor suppressor gene, because in a way it is stopping MDM2, which is going to degrade P53. So it is a tumor suppressor gene. And P16 is also a tumor suppressor gene, because this P16, the function of P16 is to block this cyclin CDK complex, and when this is blocked, then the cell cycle stops from progressing and decreases proliferation. So this is what happens. P10 here is a tumor suppressor gene, P16, and these are all tumor suppressor gene. So now I want to tell you, imagine there is a disease where there is loss of P10. There is going to be increased cell survival in this pathway. Okay, so Any disease with loss of PTEN or PTEN mutation can have melanoma because this pathway is going to be, PTEN is not there. So this cell survival pathway is just going to keep on happening. So which condition has loss of PTEN mutation? Loss of PTEN or mutation of PTEN, the disease is known as Cowden syndrome. Okay. So Cowden syndrome has increased risk of melanoma. We know now why it has increased risk of melanoma. Okay. So this is one condition. Apart from that, I've told you two diseases, ataxia telangiectasia, in relation with skin cancers, risk of skin cancers, right? Ataxia telangiectasia and xeroderma pigmentosum. So what happens in ataxia telangiectasia? There is DNA repair defect. Whenever chromosome break happens, usually the patients can go ahead and repair the DNA. But in ataxia telangiectasia, there is a DNA repair defect. And because of that, repair is difficult. Okay. In xeroderma pigmentosum, what happens is there is nucleotide excision repair. Okay. There is nucleotide excision repair. So because of these reasons, it is difficult to repair damaged DNA, and these keep replicating and they are prone to developing all kinds of skin cancers, including melanoma skin cancers. Also remember here that the most common mutation which is associated with our melanoma is BRAF mutation. Okay, this is very important because see, everywhere you can see there are treatment options everywhere in melanoma. See, this tyrosine kinase pathway, you can give tyrosine kinase inhibitors over here. For BRAF, you can give BRAF inhibitors over here, right? One example of BRAF inhibitor is vemurafenib. And then you can have MEK inhibitors. For everything, you have inhibitors. So that is why understanding of these molecular pathways are important because they can be inhibited and can be treated. Okay, now we'll move ahead and discuss what are the two growth patterns of melanoma. We have radial growth pattern. Okay, radial growth pattern is nothing but growing like this, and then vertical growth pattern which is growing like this. So you can just guess which one has a better prognosis. Radial growth pattern has a better prognosis, or vertical growth pattern has a better prognosis. Whenever depth is more, invasion is more, it is going to be bad, right? It is going to penetrate into deeper tissues. So any melanoma with a radial growth pattern has a good prognosis. Okay. In morphology, you have to remember A, B, C, D, and E of melanoma. A is asymmetry. B is irregular border. Border is irregular. C is color. Color is nothing but in melanoma, in nevus, usually the color is uniform. But in melanoma, you can see that there is a lighter pigment over one place, there is a darker pigment over one place. D is depth. And E is evolution. Evolution is nothing but rapid increase in size or rapid change in color or rapid change in the texture or anything of the lesion. So that these five features are suggestive of melanoma. Okay, so you can see here, this is a lesion. This is a melanoma lesion. You can see that this is very asymmetrical. A nevus would be symmetrical, like round, or they will have a well-defined border. Okay. But malignant melanoma here is asymmetrical. You can see here. And then irregular border. Correct? And then color. You can see the inside of the lesion, this is lighter in color, and the outside of the lesion, this is darker in color. Okay. So again, color. And then D for depth. So this lesion can be invasive also. You can see over here how deep this is going inside the dermis, right? And then we have evolution. Evolution, you can see over time, change in the lesion. Okay. So that is it for melanoma. We discussed melanoma. Now we move ahead and go to the next question, which is molluscum contagiosum. Molluscum contagiosum is nothing but a infection caused by pox virus. So the gross appearance would be umbilicated skin colored papules. So it will have a protrusion like this in the shape of a umbilication. Okay. And then in microscopy, you can see that the lesion appears like a crater. It is like a crater-like lesion, or it can have large nodules which are eosinophilic. Okay, it can have large eosinophilic nodules which are known as Henderson Patterson bodies. Okay, these are Henderson Patterson bodies. These are inclusions caused by the pox virus. Okay, these are inclusions caused by the pox virus. Okay, so this is about molluscum contagiosum. Now we have already discussed xeroderma pigmentosum. Xeroderma pigmentosum is an autosomal recessive disorder. Okay, this is an autosomal recessive disorder. This is a genetic disorder with defective DNA repair. There is defect in DNA repair, and especially in case of xeroderma pigmentosum, we saw that there was defect in nucleotide excision repair. Okay, because of accumulation of this DNA, defective DNA, these patients are prone to many mutations, ultimately leading to all types of skin cancer. So, xeroderma pigmentosum patients may have melanoma skin cancers as well as non-melanoma skin cancers like squamous cell carcinoma. So, everything can happen in this patient. They are autosomal recessive and they have defective nucleotide excision repair. Now, this I think we have already discussed actinic keratosis and Bowen's disease. So, these are the two main pre-malignant conditions of squamous cell carcinoma. And I would like to tell you a few more pre-malignant conditions which are associated with melanoma. Okay. Melanoma associated pre-malignant conditions. So we have to know one most important thing is dysplastic nevi. Remember dysplastic nevi. There are many types of nevus cells. Okay, nevus is a very common condition, right? But dysplastic nevi, this can be familial as well. Okay, dysplastic nevi can be familial as well as sporadic. Sporadic meaning it can appear without any familial condition. So this is dysplastic nevi. This is a predisposing condition for melanoma. Okay. Our ABCD of melanoma we have already discussed. I will just review it for you. A for asymmetry, B is for irregular border, C is for change or inconsistency in color throughout the lesion. Okay. D is for depth or diameter. E is for evolution of the lesion. So this is the ABCD E of melanoma. They've asked in your previous exam ABCD of melanoma, but be aware there is an E also. Now, let's discuss the other condition which is asked. We have Sézary syndrome, mycosis fungoides. Now, Sézary syndrome, the name is very much confusing. The name is very much, it's not giving any clue for you. You either have to know the lesion or this mycosis fungoides is very misdirectional because mycosis and fungoids, everything points towards a fungal infection. But no, remember, this is a cutaneous T-cell lymphoma, okay, with skin lesions and erythroderma. This used to present as erythroderma in the beginning, and then this is a misnomer that people thought this was a fungal infection, but this was actually a cutaneous T-cell lymphoma. So I'll tell you a few features which you have to write regarding mycosis fungoides. Okay, first of all, there are Sézary cells in this lesion. What are Sézary cells? Sézary cells are cells with cerebriform nuclei. What is cerebriform? Cerebriform is resembling the structure of brain. So usually this is the epidermis, right? There is lots of lymphocytic infiltration. Okay, you have ready cells or something like this. Okay, I'll just draw it again for you. We have epidermis over here. Okay, and this looks something like this. And this area is known as the papillary dermis. And then you have reticulated areas over here. This is known as the reticular dermis. Okay, and these are our epidermal cells which are present. And this is our stratum corneum. Correct? So we have cells in Sézary syndrome which have cerebriform nucleus which has enfoldings like this, like the sulci and gyri of a brain. So that is what cerebriform nuclei means. Okay. So these kind of cells you can see infiltrating in the dermis. Also, there is another important feature which is seen here, which is epidermotropism. Okay. Remember, lymphocytes will only be seen in the dermis and perivascular areas in your skin. Okay, whenever you see lymphocytes inside the epidermis, that means there is something wrong. So, in this condition, you can see lymphocytes are going to go into the epidermis, and into the epidermal cells, you will see lymphocytes. Okay, also, these lymphocytes will go in and make a cluster. Many lymphocytes will join together and make a cluster. So this is known as quadrature microabscess. Okay, these are abscess-like collections of lymphocytes present in the epidermis. So these are the three important things which we need to know about Sézary syndrome. First, we should know that this is a cutaneous T-cell lymphoma. This presents with erythroderma because these clues are important if you get a case-based question. Also, in histopathology, you have to know these three important features, which is Sézary cells with cerebriform nuclei, and these cells going into the epidermis, causing epidermotropism, and these lymphocytes making a cluster-like appearance, which is known as quadrature microabscess. Okay, so these are the things which you need to know. Now we have already discussed Cummins disease, but I'll just review it for you. That we know that there is a full thickness dysplasia. Okay, so we know that there is a stratum corneum over here, and we have our other layers of the epidermis over here, right? And then finally at the end, we're going to have our basal layer. Okay, and then the basal layer has a basement membrane. So whenever the dysplasia is full thickness, then this is known as Bowen's disease. So this is the Bowen's disease. This is normal, and you can see in Bowen's disease there is full thickness dysplasia and the basement membrane is always intact in Bowen's disease. Okay. So what carcinoma will arise from Bowen's disease? It will be squamous cell carcinoma. It's a precursor lesion of squamous cell carcinoma. Then the last chapter which we have to discuss is psoriasis. Last short answer question. Okay. Psoriasis is a chronic inflammatory skin disease with erythematous plaques and silvery scales. Silvery scales, please remember this word because you can be asked this in a case-based question also. You can be asked like a 40-year-old female presents with itchy silvery flakes, okay, in the flexor aspect of her forearm or something like that. This can be asked for you. And this case, whatever I had told you right now, is a classic case of psoriasis. Okay. What are the things which you have to remember in psoriasis? Similarly, I tell you, in psoriasis, the main pathology over here is increased cell turnover, increased epidermal turnover. So there's going to be increased epidermal turnover. So what will happen if there is increased epidermal turnover? I told you there is going to be more stratum corneum, right? Okay, fine. And then you're going to have other layers of cells. Usually in the stratum corneum, what you have are dead cells, right? So dead and degenerated cells, they usually do not have nucleus, okay? But in psoriasis, what happens is usually the cell turnover from basal layer to going into these phases and going into stratum corneum, the full cycle takes about 28 days. But in psoriasis, it takes about only 4 to 5 days. So there's such quick cell turnover. Okay, because of such quick cell turnover, you will have nucleus in the stratum corneum. Okay, you will have nucleus in all cells because there's no time to shed the nucleus. There's such quick cell turnover. You're going to have a thick layer of cells, with nucleus in them. Okay, so this is known as parakeratosis. Okay, parakeratosis is nothing but nucleated cells in the stratum corneum. This is a feature of psoriasis. Number one, most important feature, remember, parakeratosis. Okay. Number two, most important feature which you have to remember is we saw that there was papillary dermis and then there was reticular dermis. Right? So there is going to be longer and thicker papillae. Longer and thicker papillae in the papillary dermis. So this is called hyperplasia, papillary hyperplasia. Okay, because usually the papillae is thin and short, but in psoriasis you're going to have a thick papillae like this. Okay, so papillary hyperplasia. And third one is the most important, and this is what you get asked time and again. This is what is known as Monro microabscess. We saw portrait microabscess in sensory syndrome, right? So this is Monro microabscess. What is Monro microabscess? Neutrophils, which are present here, neutrophils, they come in, they accumulate in the epidermis. Okay, they are a collection of neutrophils. Like small pustules, they accumulate here and there in the epidermis. Okay, these are neutrophils, they accumulate in the epidermis. So clusters of neutrophilic collection here and there, is what is known as Monroe's microabscess. So remember these three important features for psoriasis. First of all, there is parakeratosis because of increased cell turnover, and then thicker and longer papillae because of papillary hyperplasia. Okay, and then Monroe's microabscess. So these are the three important histologic features which you have to remember. Now we'll go ahead and discuss a few MCQs for you, okay, to retain the topics very well. So first one is, what is the most common site of malignant melanoma? Okay, we have options saying scalp, palms, back in men and legs in women, and abdomen. So I'll take a few seconds for you to think, and then we can discuss the answer. So the most common site of malignant melanoma is back in men and legs in women. Okay, this is the most common site. Scalp is not the most common site, even though it is a sun-exposed site. Back in men and legs in women are the most common site which you have to remember. Okay. Now, which of the following is characteristic feature of basal cell carcinoma? I hope we have discussed basal cell carcinoma also. So basal cell carcinoma, the most characteristic feature of basal cell carcinoma is supposed to be pearly plates with telangiectasia. Now let's discuss the other options. Ulcerated crusted lesions on mucosal surface. This could be squamous cell carcinoma. Ulceration is a very important feature of squamous cell carcinoma. Now see, this is pigmented nodules with irregular borders. Very classic melanoma. Okay. Plaques with silvery stain, again very classic psoriasis. Okay, so how easy is it that you can just get a one line of case and then get the diagnosis? So remember these classic examples of clinical history. Which mutation is commonly associated with the development of malignant melanoma? Again, very easy, which we discussed. The answer is BRAF mutation. BRAF mutation is the most common mutation in malignant melanoma. Now, let's move on to this question. What is the typical histopathologic feature of Bowen's disease? Now, I'll just take a few seconds. You read through the options and then we can discuss it. Okay. So here we have full thickness epidermal dysplasia without invasion, dermal infiltration by atypical lymphocytes, formation of case-eating granulomas, spongiosis in the epidermis. Okay, so these are the features. Full thickness epithelial dysplasia, epidermal dysplasia is what is Bowen's disease. We have already discussed this. Dermal infiltration of atypical lymphocytes, Sézary syndrome. Also, we have discussed. Okay. Formation of case-eating granulomas, tuberculosis. Spongiosis in epidermis, this we haven't discussed, but this is a feature of dermatitis. Eczema, eczematous dermatitis. So that is spongiosis, the feature of eczematous dermatitis. So now the next question. This is a very easy question, just for a review. ABCT criteria includes all except asymmetry. It includes, yes. Irregular border, yes, definitely. Yes. Color variation, yes, correct. Depth of the lesion, yes. All of these are, so there's no except over here. So all of these are criteria for melanoma. So depth, color, variation in color, border, and asymmetry, everything is a feature. Okay. So this was a trick question. So that is it for today's class. Thank you. Let's meet in the second skin lecture soon. Okay. Bye bye.